Hello, this is Dinesh Ramaya. Welcome to the lecture on Airway Anatomy and Innervation. The goal of this lecture is to learn the anatomy of the airway, its innervation, and anesthetic implications. A general understanding of the airway structure is critical for establishing and maintaining the airway. And for the purpose of description, the airway is divided into the upper airway, which extends from the nose to the glottis or thoracic inlet, and the lower airway, which includes the trachea, the bronchi, and the subdivisions of the bronchi. Traditionally, the upper airway is classified as including the nose, the oral cavity, and the pharynx. The function of the upper airway includes conduction of air and also serves other important functions such as olfaction, deglutition, and phonation, and also to prevent foreign materials from entering the lower airway. This picture shows the three main subdivisions of the upper airway, which includes the nasopharynx, oropharynx, and the laryngopharynx, in addition to the nose and the oral cavity and the laryngeal apparatus, which includes the epiglottis, the vestibular fold, the true vocal cords, the thyroid cartilage, and the cricoid cartilage. It also shows the various sinuses like the frontal sinus, the maxillary sinus, and the sphenoidal sinus. The nose is made up of bone and cartilage. The two nasal fossa extend 10 to 14 centimeters from the nostrils to the nasopharynx. The two fossa are divided mainly by the cartilaginous septum together with the two medial portions of the lateral cartilages. The nasal septum is primarily composed of the perpendicular plate of the ethmoid bone descending from the cribriform plate, the septal cartilage, and the vomer. The nasal passages are also called choanae, and there is vibrissae filter which filter the incoming gas, also called as the whiskers. The first 1/3 of the nasal mucosa is covered with stratified squamous epithelium, whereas the posterior 2/3 is pseudostratified ciliated columnar which secrete mucus secretions. There is extensive capillary network, and hence it is essential to constrict or dilate to change the blood flow prior to instrumentation. The figure A shows the cartilaginous part of the nasal septum anteriorly and the perpendicular plate of the ethmoid bone posteriorly, forming the nasal septum. It also shows the frontal sinus and the sphenoidal air sinuses. Figure B demonstrates the superior, middle, and inferior turbinates and the cribriform plate of the ethmoid bone. Disruption of the cribriform plate of the ethmoid bone secondary to facial trauma or head injury may allow direct communication with the anterior cranial fossa, and the use of positive pressure mask ventilation in this scenario may lead to entry of bacteria or foreign materials, resulting in meningitis or sepsis. In addition, nasal airways, nasotracheal tubes, and nasogastric tubes may be inadvertently introduced into the subarachnoid space. The nasal cavity has the superior, inferior, and the middle turbinates, and each nasal fossa provides approximately 60 square centimeters of surface area per side for warming and humidifying the inspired air. The nose is able to pre-warm the inspired air from 15 degrees Celsius with a humidity of 40% to 33 degrees Celsius and a humidity of 98% as it exits the nasal cavity. Approximately 10,000 liters of ambient air pass through the nasal cavity per day, and about 1 liter of moisture is added to the air during this process. The inferior turbinate is a highly vascular membrane and usually limits the size of the nasotracheal tube that can be passed through the nose. As a result, damage to the lateral wall may occur during vigorous attempts at nasotracheal intubation. The arterial supply to the nasal cavity is mainly from the ophthalmic artery, branches of the maxillary, and branches of the facial artery. The Kieselbach's plexus, where these vessels anastomose, is situated in Little's area on the antero-inferior portion of the nasal septum, and this is a common source of clinically significant epistaxis. The primary functions or the physiology includes respiration, olfaction, humidification of the air, filtration, and phonation. The nose has the ability to filter particles down to 5 microns in diameter. And the two factors which decrease the humidification and filtering capability of the nose is mouth breathing and placement of a nasal endotracheal tube. The pharynx is about 12 to 15 centimeters long and extends from the base of the skull to the level of the cricoid cartilage anteriorly and the inferior border of the C6 vertebrae posteriorly. The pharynx is widest at the level of the hyoid bone, which is approximately 5 centimeters in diameter, and narrowest at the level of the esophagus, which is about 1.5 centimeters in diameter, and this is the most common site for obstruction after foreign body aspiration. Traditionally, the pharynx is further subdivided into nasopharynx, oropharynx, and the laryngopharynx. The nasopharynx primarily has a respiratory function and lies posterior to the termination of the turbinates and nasal septum and extends to the soft palate. The oropharynx has primarily a digestive function, starts below the soft palate and extends to the superior edge of the epiglottis, while the laryngopharynx lies between the 4th and the 6th cervical vertebrae and starts at the superior border of the epiglottis and extends to the inferior border of the cricoid cartilage. The wall of the pharynx consists of 2 layers of muscles, an external circular layer and an internal longitudinal layer. Each layer is composed of 3 paired muscles, the stylopharyngeus, the salpingopharyngeus, and the palatopharyngeus muscle, which form the internal layer. They primarily elevate the pharynx and shorten the larynx during deglutition. The superior, middle, and inferior constrictors form the external layer, and they help in advancing the food in a coordinated fashion from the oropharynx into the esophagus. The internal layer is innervated by the glossopharyngeal nerve, while the constrictors are innervated by the sensory and motor branches from the vagus, the glossopharyngeal, and external branch of the superior laryngeal nerve. The inferior constrictors are additionally innervated by branches of the recurrent laryngeal nerve and the external laryngeal nerves. The roof of the oral cavity or the mouth is formed by the hard bony portion or the hard palate and the soft fleshy portion, which is the soft palate. Uvula is the soft fleshy structure, and the tonsils or the palatine tonsils are located on each side of the oral cavity. Figure A shows the tonsillar pillars, the uvula, and the hard and soft palate, whereas figure C shows the hypertrophied tonsils. The nasopharynx is located posterior to the nasal cavity and lies posterior to the termination of the turbinates and nasal septum and extends to the soft palate. It includes the pharyngeal tonsils or the adenoids. The Eustachian tubes connects the middle ear and nasopharynx, and infections of the middle ear called otitis media is a complication of prolonged nasotracheal intubations. And the Eustachian tubes open into the lateral wall of the nasopharynx. The oropharynx lies behind the oral cavity and starts below the soft palate and extends to the superior edge of the epiglottis. The lingual tonsils lie at the root of the tongue on either side. The hypopharynx or the laryngopharynx lies between the base of the tongue and the entrance to the esophagus and lies between the 4th and the 6th cervical vertebrae, starts at the superior border of the epiglottis and extends to the inferior border of the cricoid cartilage. The larynx lies in the adult neck opposite the 3rd through 6th cervical vertebrae, extends from the base of the tongue at the hyoid bone to the first ring of the trachea. The inlet to the larynx is bounded anteriorly by the upper edge of the epiglottis, posteriorly by a fold of the mucous membrane stretched between the two arytenoid cartilages, and laterally by the epiglottic folds. The main function of the larynx acts as a watchdog of the airway and an organ of phonation. The larynx is made up of bone and cartilages, which form the skeletal framework. It is also made up of ligaments, membranes, and muscles. The three cartilages which form the larynx include the epiglottis, the thyroid cartilage, and the cricoid cartilage. This is a picture of direct laryngoscopic examination of the larynx, which shows the vallecula, the anterior commissures, the posterior commissure, the glottic opening, the vocal cords, the epiglottis, and the tracheal rings. This is an anterior view of the larynx, showing the epiglottis, the hyoid bone, the thyroid membrane, the thyroid cartilage, the cricoid cartilage, the cricothyroid membrane, and the muscles, the trachea. This is another picture of anterior and posterior view of the larynx, showing the epiglottis, the hyoid bone, the cuneiform cartilages, the paired arytenoids, the inferior cornea of the thyroid cartilage, the cricoid cartilage, and the trachea. The hyoid bone suspends and anchors the larynx during respiratory and phonatory movement. It is a U-shaped and is named after the Greek word hyoides, meaning shaped like the letter epsilon. It has a body which is about 2.5 centimeters wide and 1 centimeter thick, and a greater and lesser horns, or the cornea. The hyoid does not articulate with any other bone, and it is attached to the styloid process of the temporal bone and to the thyroid cartilage by the thyroid membrane and muscles. The intrinsic tongue muscles originate on the hyoid, and the pharyngeal constrictors are also attached to the hyoid bone. Hyoid bone also provides a landmark for blocking the superior laryngeal nerve. 9 cartilages provide the framework of the larynx. These are the unpaired thyroid, cricoid, and epiglottis, and the paired arytenoids, coniculates, and cuneiforms. They are connected and supported by membranes, synovial joints, and ligaments. When the ligaments are covered by mucous membrane, they are referred to as folds. The thyroid cartilage is the longest laryngeal cartilage and the largest structure in the larynx. And the thyroid cartilage forms the anatomic lower limit of the larynx. It is the only complete cartilaginous ring in the upper airway. The cricoid cartilage is approximately 1 centimeter height anteriorly, but almost 2 centimeter height in its posterior aspect. It attaches to the thyroid cartilage by the cricothyroid membrane. And cricoid cartilage is a landmark for laryngotracheal anesthesia as well as a surgical airway. The cricoid cartilage is shaped like a ring and is frequently said to have a signet ring shape. As it is the only complete ring in the upper airway, gentle downward pressure on the cricoid cartilage helps to prevent passive regurgitation without any significant airway obstruction, what is called as a Selleck maneuver or cricoid pressure. The tracheal rings are connected to the cricoid cartilage by ligaments and muscles. The thyroid cartilage is the longest laryngeal cartilage and the largest structure in the larynx. The thyroid notch lies in the midline at the top of fusion of the two laminae. The superior and inferior cornu of the thyroid are slender and posterior directed extensions of the edges of the laminae. The lateral thyrohyoid ligament attaches the superior cornea to the hyoid bone, and the cricoid cartilage articulates with the inferior cornea at the cricothyroid joint. The movements of these joints are rotatory and gliding and result in changes in the length of the vocal cords. The two arytenoids are cartilages and are shaped like three-sided pyramids, and they lie in the posterior aspect of the larynx. The arytenoid cartilages are described as a ball and socket with three movements: rocking or rotating, gliding, and pivoting, that control adduction and abduction of the vocal cords. All such joints can be affected by rheumatoid arthritis. Cricoarytenoid arthritis is present in majority of the patients with rheumatoid arthritis and other autoimmune diseases and can cause life-threatening upper airway obstruction. The epiglottis is shaped like a leaf and is found between the larynx and the base of the tongue. It is primarily composed of fibroelastic cartilage. The anterior surface of the epiglottis is concave, and this in combination with laryngeal elevation aids in airway protection during swallowing. The pouch-like areas found between the median and lateral folds are called the valleculae. The tip of the properly placed Macintosh laryngoscope blade rests in this area called the valleculae. And the valleculae is the common site of impaction of foreign bodies such as fish bones in the upper airway. The trachea measures approximately 15 cm in adults and is circumferentially supported by 17 to 18 C-shaped cartilages with a membranous posterior aspect overlying the esophagus. In an adult, the first tracheal ring is anterior to the sixth cervical vertebrae. The trachea ends at the carina at the level of the fifth thoracic vertebrae. The right principal bronchus is larger in diameter than the left and deviates from the plane of the trachea at a less acute angle. The cricothyroid membrane is a fibroelastic membrane lying over the tracheal mucosa, and in adults typically measures about 9 mm in height and about 3 cm in width, and is located in the anterior neck between the thyroid cartilage superiorly and the cricoid cartilage inferiorly. Any incisions or needle punches to the cricothyroid membrane should be made in its inferior third and be directed posteriorly because of the neurovascular bundle which runs along the superior margin of the cricoid cartilage. This is a picture which shows the relationship of the superior thyroid artery, the cricothyroid artery, in relation to the cricothyroid membrane. The superior thyroid artery is the first branch of the external carotid artery, while the cricothyroid artery is a branch of the superior thyroid artery and runs in the upper portion of the cricothyroid membrane. Care should be exercised during a surgical airway or placement of a tracheal hook during tracheostomy. The larynx is made up of extrinsic and intrinsic group of muscles. The extrinsic group connects the larynx with its anatomic neighbors such as the hyoid bone and modifies the position and movement of the larynx, whereas the intrinsic group facilitates the movements of the laryngeal cartilages against one another and directly affects the glottic movement. Among the extrinsic muscles, the suprahyoid group, which includes the stylohyoid, geniohyoid, mylohyoid, thyrohyoid, digastric, and the stylopharyngeus muscles, and the infrahyoid muscles include the omohyoid, sternothyroid, thyrohyoid, and sternothyroid muscles. The main function of the intrinsic musculature is to lower the larynx and assist in deglutition. The main muscles of the intrinsic group include the aryepiglottic, and thyroepiglottic, thyroarytenoids, and vocalis, oblique and transverse arytenoids, lateral and posterior cricoarytenoids, and the cricothyroids. And the main function of the intrinsic group of muscle is to open the vocal cords during inspiration, close the cords and the laryngeal inlet during deglutition. and also to alter the tension of the cords during phonation. This is a box which shows the function of the various extrinsic muscles of the larynx. The sternothyroid, sternohyoid, and the thyroid are primarily help in depressing the larynx, whereas the inferior pharyngeal constrictor assists in swallowing, and the stylopharynges assists folding of the thyroid cartilage. This is a box which shows the various functions performed by the intrinsic muscles of the larynx. The posterior cricoarytenoid is an abductor of the vocal cords, while the lateral cricoarytenoids and transverse arytenoids are adductors and close the glottis. The oblique arytenoid also, along with Airway epiglottic, closes the glottic opening, whereas the vocalis relaxes the cords and thyroid arytenoid relaxes the tension of the cords, similar to the cricothyroid muscle. This picture shows the innervation of the intrinsic muscles of the larynx. The motors apply to all the laryngeal muscles except the cricothyroid muscle is provided by the recurrent laryngeal nerve, and the external branch of the superior laryngeal nerve supplies the motor innervation to the cricothyroid muscle. Both the superior laryngeal nerve and the recurrent laryngeal nerve are derivatives of vagus nerve. The space between the true vocal cords is called as the rima, glottis, or the glottic opening. The glottis is further subdivided into two parts, the anterior intermembranous section and the posterior intercartilaginous part. The anterior section is situated between the two vocal cords, and the posterior passes between the two arytenoid cartilages. This picture shows the normal position of the vocal cords during phonation and inspiration, and note the abduction of the cords during phonation. Note the adduction of the cords during phonation and abduction of the cords during inspiration. This slide is a representation of the position of the vocal cord in different types of vocal cord palsies. The recurrent laryngeal nerve carries both abductor and the adductor fibers to the vocal cords. The abductor fibers are more vulnerable, and moderate trauma causes pure abductor paralysis. Severe trauma causes both abductor and adductor fibers to be affected. In general, pure adductor paralysis does not occur as a clinical entity. In case of a pure unilateral abductor paralysis, in this case a left abductor paralysis, both cords meet in the midline on phonation because the adduction is still possible on the affected side, whereas only the normal cord abducts during inspiration and the paralyzed left vocal cord stays in the midline. In case of a complete unilateral recurrent laryngeal nerve palsy, both the abductors and the adductors are affected. As a result, on phonation, the unaffected vocal cord crosses the midline to meet the paralyzed counterpart. On phonation, whereas on inspiration, the unaffected vocal cords move to full abduction, and hence there is no respiratory obstruction. With a complete bilateral recurrent laryngeal nerve palsy, each vocal cord lies close to the midline between abduction and adduction, and a reasonably wide glottic opening is maintained. Therefore, bilateral incomplete palsies is more dangerous than a complete variety, because in case of a incomplete bilateral recurrent laryngeal nerve palsy, which involves bilateral abductors results in complete adduction of both vocal cords and can result in complete airway obstruction, which could be life-threatening. The recurrent laryngeal nerve may be injured due to thyroid and parathyroid surgeries, malignancy or benign process of the neck, trauma, pressure from an endotracheal tube or laryngeal mask airway, and stretching of the neck. The left nerve is likely to be paralyzed twice as frequently as the right one because of its close relationship to the intrathoracic structures. Damage to the superior laryngeal nerve during thyroidectomy is the most common cause of voice change due to the injury to the external branch of the superior laryngeal nerve. And as I mentioned earlier, incomplete bilateral damage to the recurrent laryngeal nerve results in severe respiratory distress because of the unopposed action of the bilateral adductor muscles. Coming to the innervation of nasal passage in the nasopharynx, the anterior ethmoidal nerve innervates the anterior third of the nares, while the greater and lesser palatine nerves innervate the posterior 2/3 of the nares. The oropharynx is innervated by branches of the vagus, the facial nerve, and the glossopharyngeal nerve. The glossopharyngeal nerve, its 3 branches, supply sensory innervation to the posterior third of the tongue, the vallecula, the anterior surface of the epiglottis, by the lingual branch, the walls of the pharynx, by the pharyngeal branch, and the tonsillar branch supplies the tonsils. The larynx is innervated by the 10th cranial nerve, the vagus. The 2 branches of the vagus, including the recurrent laryngeal nerve and the superior laryngeal nerve, provide innervation to the larynx. The recurrent laryngeal nerve supplies all the intrinsic muscles of the larynx except the cricothyroid, and also provides sensory innervation to the larynx below the vocal cords. The superior laryngeal nerve has the internal and external branch, and the internal branch provides sensory innervation to the posterior epiglottis up to the vocal cords. The external branch of the superior laryngeal nerve provides motor innervation to the cricothyroid muscle. The recurrent laryngeal nerve provides sensory innervation to the tracheobronchial tree up to and including the vocal cords, and also provides motor innervation to the intrinsic laryngeal musculature except the cricothyroid muscle. This concludes the lecture on airway anatomy and innervation of the airway, and thank you for watching.